closely, you will notice that most of the overnight successes took a long time. So yes, there is no shortcut to success wherever you are at your journey right now. Start taking baby steps and you will be surprised when you achieve your success. You will smile back at your journey and you will see that yes, it was not magic. It took so much of love and so much of effort, and the success does not hold any significance if you did not enjoy the journey. So enjoy the journey. The more you enjoy the journey, the more chances it will be that you will be successful. So now we start with the embryology, the development of the inner ear, and along with some part of anatomy of the inner ear. Now this is something that we are doing in the beginning itself because for the past few years there are so many questions that are being asked from this part, and this is something that you find a little confusing. But I just want to show you how simple it is. So yes, I hope I have all your attention, and let us start with the embryology or the development of the inner ear, a very, very important topic of your exams. So can you tell me what the inner ear is known as? Yes, the inner ear is known as labyrinth, and the inner ear or the labyrinth is in two parts. It is a membranous or a sac-like structure surrounded by a bone. So the membranous or the sac-like structure, like a balloon, like a membrane, a membranous balloon, yes. So that is what is known as membranous labyrinth, and the bony covering is what is known as bony labyrinth. So the most basic structure of the inner ear or the labyrinth is something like this. It has a membranous sac-like structure here. This is what is known as the membranous labyrinth. This is the membranous labyrinth, and yes, this membranous labyrinth inside, this balloon inside contains a fluid. So this is a holy balloon containing the fluid inside. This fluid inside is what is known as endolymph inside, so endolymph. Now the bony covering outside is what is known as, this is what is known as the bony labyrinth, and the bony labyrinth also inside contains a fluid. This fluid is what is known as in the periphery outside the membranous labyrinth, so it is known as perilymph. So inside the membranous labyrinth is endolymph, outside it is perilymph. So the membranous labyrinth is bathing in fluid outside and it contains fluid inside. So this is the most basic structure of the inner ear that anybody can think of. Now actually, this round balloon that I have shown as the membranous labyrinth and the round bony labyrinth is actually not round in shape. It has got a very beautiful shape which we will just see, but yes, the basic architecture remains like this. So now we start with the membranous labyrinth. The membranous labyrinth develops from a specialized area of surface ectoderm. So the membranous labyrinth is developing from where? From the surface ectoderm. From surface ectoderm. Yes, this is a question of your exam. It develops from where? From surface ectoderm that overlies the developing hindbrain that we are seeing here. Now this is what is known as otic placode. This deepens down to form the otic pit, and now this separates from the surface ectoderm to form what is known as otic vesicle. So this is known as otic vesicle. Now the rest of the membranous labyrinth develops from this otic vesicle. So now what will happen? The otic vesicle will give one outpouching, as here. Now it will give two outpouchings. Now it will give three outpouchings, four outpouchings. Ultimately, it will become a shape like this. And this is what we call as membranous labyrinth, the beautiful shape that I was talking about. So this complex shape, or you can call it the beautiful shape of the membranous labyrinth, this membranous labyrinth actually develops from a single sac-like structure. It is one balloon that you're giving different outpouchings ultimately to give it a shape like this. Why am I repeating again and again? It is one balloon. It is one sac from which this structure develops, this complete structure develops. Yes. Does the membranous labyrinth communicate anywhere with anything? Yes or no? Does the membranous labyrinth communicate anywhere with anything? Does the membranous labyrinth open anywhere into anything? No. So let us come back to that the basic architecture that we just saw. It is exactly like this. Yes, the membranous labyrinth is a complete sac. It is not opening anywhere into anything. Is that clear? It is just that it is not in this round shape. So now that we have started with the inner ear, what are the things that we need to know in the inner ear? First, we need to know the structure of the membranous labyrinth. We need to know the function of the membranous labyrinth. We need to know the structure of the bony labyrinth and its function. Now, also what we need to know is that the inner ear is connected laterally to something, medially to something. Yes, so that you will tell me. What lies lateral to the inner ear? Yes, very good. The middle ear, which means we know that we have the tympanic membrane. The sound goes from the external ear through the tympanic membrane to the middle ear, and then from the middle ear it goes into the inner ear. So as we are going from the external ear, medially we are entering into the inner ear. So what lies lateral to the inner ear? Yes, the middle ear. Yes. And what lies medial to the inner ear? Yes, medial to the inner ear we just saw is the brain, is the cranium. Yes. So which means that there will be connections between the middle ear and inner ear. Yes. So there will be connections, openings between the middle ear and inner ear. And also there will be openings or connections between the inner ear and the brain. So we need to know what these connections are. If we want to pass something from the middle ear into the inner ear, we have to know what options we have. If we are passing something from the inner ear to the brain, or something is going from the inner ear to the brain, coming from the inner ear to from the brain into the inner ear, we have to know what is the connection through which it has traversed. So these connections between the middle ear, inner ear and the brain are very, very important to know the normal connections and the abnormal that can occur through these connections. So this is what we are expected to know in the inner ear. So with that, we have now just seen the structure of the membranous labyrinth, that this membranous labyrinth has this beautiful shape and it is a complete sac-like structure. It is not opening anywhere. It is not connected anywhere to anything. It contains a fluid inside. Yes, the fluid, the endolymph. That fluid endolymph is produced in the membranous labyrinth. It is absorbed in the membranous labyrinth itself. So now let us see, when completely formed, what are the parts of the membranous labyrinth. Now let us see how this membranous labyrinth looks like. Let us see the structure. So in the membranous labyrinth, we have the three semicircular canals. The three semicircular canals are named according to whichever direction they are going. So they are known as the lateral, the posterior, and the superior semicircular canal, and the superior is also known as the anterior semicircular canal. So the three semicircular canals open into a common structure which is known as utricle. This is known as utricle. Now the three semicircular canals open into the utricle by 5 openings. Now when there are 3 semicircular canals, there should be 6 openings. Why only 5? Yes, because as we can see here, the superior and posterior semicircular canal have a common opening, a common tract which is known as a common crus, or it is known as crus commune. It is known as crus commune. Common crus or crus commune, because of which the 3 semicircular canals open into the utricle not by 6 openings but by 5 openings. Now after the utricle, this structure is what is known as the saccule. The utricle and saccule give 2 ducts which join to form the endolymphatic sac. So this here is what is the endolymphatic sac. Endolymphatic sac. So now can you answer this question for me? The endolymphatic sac drains the endolymph into the CSF. True, false? Very good, it is false. Why not? Yes, we just saw that this membranous labyrinth is a complete sac-like. It is a closed structure in itself. It is not opening anywhere. So no, it does not drain the endolymph anywhere. What does it do? It absorbs the endolymph. So the endolymphatic sac is responsible for absorption of endolymph. It absorbs the endolymph. Now, after the saccule, the next structure is what is known as a scala media. This is known as scala media, or it is also known as membranous cochlea. And as we are seeing here, the scala media is not a straight tube. It is coiled. Yes. So it takes turns around the bony pyramid. So suppose this is a pyramid, it takes turns around the bony pyramid. How many turns does it take? Yes, very good. It takes 2.5 to 3/4 turns. Sometimes in choice is given 2.5, sometimes is given 2.75. So whatever is given in the choice, you can mark accordingly. So it takes 2.5 to 3/4 turns around the bony pyramid. This bony pyramid around which it turns is what is known as modulus. So in the center is the bony pyramid, which is known as modulus. So this structure which we initially did as a circle here is this structure, and now quickly you are going to tell me the parts of the membranous labyrinth. Yes, you can start from anywhere, from above or below. Yes, very good. Yes, quickly tell me. Yes, we have the 3 semicircular canals. The 3 semicircular canals open into, very good, the utricle. After the utricle we have saccule. The uticular-saccular duct joins to form endolymphatic sac, responsible for production of endolymph, absorption. Yes, for absorption of endolymph. And after that we have the scala media. From the scala media is the production of endolymph. Where exactly is the production occurring, that we will see in some time. So yes, we are quickly going to write this. We have the parts of the membranous labyrinth. Yes, in the membranous labyrinth we have the 3 semicircular canals. We have the 3 semicircular canals which are known as the lateral, the posterior and the superior. Superior is also known as anterior. The 3 semicircular canals open into utricle. Yes, by how many openings? By 5 openings into the utricle. After the utricle, we have the saccule. From the utricle and saccule arise 2 ducts which join to form the endolymphatic sac, responsible for absorption of endolymph. After the saccule, the next part is what is known as scala media, and scala media is how many turns? 2.5 to 2.75 turns around the bony pyramid, which is known as modulus. So now that this complete membranous labyrinth picture we have in our mind, whenever next time ever you are going to think of the membranous labyrinth, this picture should come to your mind. So now once the membranous labyrinth is formed completely, certain areas of the membranous labyrinth undergo differentiation to form specialized sensory end organs of hearing and balance. So the inner ear has 2 functions, function of hearing and balance, which means that if there is any disease of the inner ear, the patient will present with 2 complaints. Yes, what can be the 2 complaints of any disease of inner ear? Yes, very good. Hearing loss and imbalance. Imbalance, that is vertigo. So which means that if there is any patient who has come to us with a complaint of hearing loss, along with that there is vertigo, immediately we can localize that the disease is in the inner ear. So now let us see which part of the inner ear is for hearing and which part is for balance. The sensory end organ of hearing is present in the scala media. In the scala media is the sensory end organ of hearing, and the sensory end organ of hearing in the scala media is what is known as this black thing, this dark thing that you can see. This is what is known as organ of Corti. Organ of Corti. So yes, the whole of the scala media has organ of Corti. The whole of the organ of Corti is responsible for sensing of hearing. Now, but different parts of organ of Corti sense different frequency of sounds. Can you tell me cochlea is how many turns? So organ of Corti will have how many turns? Very good. 2.5 to 3/4 turns. Yes. So different parts of the organ of Corti are responsible for sensing different frequency of sound, and this is a question that is asked in your exam. Now, if there is a male who is speaking, what is the frequency of male voice? Yes, a low frequency voice. What is the frequency of female voice? Yes, it is a high frequency voice. So will the male and the female voice be sensed by the same part of the organ of Corti? No. The basal turn is responsible for sensing high frequency sounds, whereas the apical is for low frequency sounds. So in the base we have high frequency sounds, whereas in the apex we have low frequency sounds. So this is very easy to remember. How can we remember? In the apex we have less space, so that is for low frequency. In the base there is a lot of space, so that is for high frequency sound. Now, have you heard of a disease which is known as Meniere's? Yes, do you know what happens in Meniere's? Yes, it is a disease of the inner ear where the endolymph increases in amount. And where is the endolymph? Yes, it is present in whole of the membranous labyrinth, and it is produced from the scala media. I just told you some time back. And it is, since the scala media is also the most dependent part. So which part of the scala media will get dilated if the whole of the membranous labyrinth gets dilated because of increase of endolymph? Yes, what is the most dependent part? That is the apex of the cochlea. For example, if I take this bottle and if I start filling water in it, so which part of this bottle will get filled first? Yes, the most dependent part, that is this part here. So what is that? The most dependent part of the membranous labyrinth? Yes, that is the apex. So the apex gets dilated earliest here. So if I ask you that in Meniere's, what frequency sound is affected early? Yes, very good. The low frequency sounds. Now, if I ask you that in Meniere's, the low frequency sound is affected early because the basal tone is affected first. Is that true or not? No, because the apical tone is affected first. If the basal tone was affected first, what frequency would be affected first? Yes, the high frequency. So that is what we need to know in the organ of Corti. So here what we see is that the scala media is responsible. It contains the organ of Corti. Organ of Corti, and that is for hearing. That is for hearing. And here we have the apex and the base. Apex and base. Apex is for low frequency and base is for high frequency. The rest of the membranous labyrinth is for balance. So the hearing part is only in the organ of Corti. Now the sensory end organ of balance is in the three semicircular canals in the utricle and saccule. The sensory end organ of balance in the three semicircular canals is known as cristae. Very simple to remember. C for canal, C for cristae. C for cristae. Whereas in the utricle and saccule, it is known as maculae. So in the utricle and saccule, we can see here are developing the sensory end organs of balance. And yes, so here in the utricle and saccule, it is known as maculae. It is known as maculae. Now both cristae and maculae are for balance. Then why the difference in name? Why do we call one as cristae and one as maculae? Yes, because the type of balance that they mediate is different. The type of balance that they sense is different. One is for rotational acceleration, the other is for sensing linear acceleration. So now this thing, you will think and tell me which one will be for rotational acceleration. Yes, that is very simple to remember. Yes, which one is round? Round? Yes, the semicircular canals are round. So the semicircular canals is for rotational acceleration. What is present in canal? C for canal, C for cristae. So cristae is for rotational acceleration, whereas maculae is for linear acceleration. So let us write this here. Yes, so in the utricle and saccule, we have the maculae. Maculae is for linear acceleration. Whereas in the three semicircular canals, we have cristae. Cristae is for rotational acceleration. So along with linear acceleration, the maculae is also for head tilt and for gravitational movements. So now let me ask you this. The horizontal semicircular canal is responsible for horizontal acceleration. For linear acceleration, true or false? Yes, false. All the semicircular canals are for rotational acceleration. Linear acceleration, horizontal acceleration is by the maculae in the utricle and saccule. Okay, so now whenever you think of membranous labyrinth ever, this is the picture that should come to your mind. Do you know the structure of membranous labyrinth? Do you know the function of membranous labyrinth? Yes, very good. So you keep your pen down. So now let me ask you this. How many semicircular canals do we have? Very good, 3 semicircular canals. What is the sensory end organ of balance in the scala media? Sensory end organ of balance in the scala media. What are you thinking? Is it present? No, then say no. What is present in the scala media? Yes, in the scala media, we have the sensory end organ of hearing. What is the sensory end organ of hearing known as? Organ of Corti. In Meniere's, what is affected early? High frequency or low frequency? Low frequency, because which turn is affected first? Yes, the apical turn. Basal turn is for what frequency? For high frequency. What is the sensory end organ of balance for linear acceleration? Very good. Macula. Macula is present in utricle and saccule. For rotational acceleration, we have Cristae. Cristae is present in semicircular canals. How many semicircular canals do we have? Very good, 3. The 3 semicircular canals open into utricle. By how many openings? 5. The utriculosaccular ducts join to form endolymphatic sac, which is responsible for production of endolymph. Yes or no? No? It drains the endolymph into the CSF? Yes, no? No. Then what is it responsible for? Yes, for absorption of endolymph. So next time, whenever you read membranous labyrinth, whenever you hear membranous labyrinth, this picture should come to your mind. The complete structure and the complete function. Now, once the membranous labyrinth is formed completely, the mesoderm that surrounds the membranous labyrinth, it first gets differentiated into cartilage, and then this cartilage forms bone. It gets differentiated into bone to form the bone around the membranous labyrinth, and this bone around the membranous labyrinth is what we call as bony labyrinth. So this bony labyrinth will take the shape of membranous labyrinth, and the parts are named according to the shape. So what are the parts of the membranous labyrinth? If you will tell me, I will tell you the parts of the bony labyrinth. So it is your work first, so you start first. Yes, okay. So what are the parts of the membranous labyrinth? Yes, start from above. Very good. The 3 semicircular canals. Yes, so around the membranous 3 semicircular canals, the part of the bony labyrinth is again known as the 3 semicircular canals. What are the 3 semicircular canals? Yes, we have the lateral, the superior and the posterior. Now I told you that these 3 semicircular canals are named according to which direction they are going to. So which means that the superior semicircular canal will go where? Where will it project? Yes, as the name, it will go superiorly. Superiorly, what is superior? What is superior to the semicircular canals? Which means what is the roof of the semicircular canal? What is the roof of the inner ear? Yes, that is the base of skull. Which means that the superior semicircular canal will bulge in the base of skull. It will project in the base of skull. So where does it project exactly? Yes, just have a look here. It projects here. It projects on the anterior slant of the protruding part of temporal bone. And this eminence which is produced by the bulging of the superior semicircular canal is what is known as arcuate eminence. It is known as arcuate eminence. And what is the significance of knowing this? Now, many times the base of skull that covers the superior semicircular canal can be dehiscent, which means that it can be gaping, it can be missing. So what will happen if it is missing? Yes, if it is missing, what will happen? Any increase in intracranial pressure will directly get transmitted to the inner ear. It will stimulate the inner ear, and the patient will come to us with complaints of inner ear pathology. But is the patient having any complaint in the inner ear? Is the patient having any defect in the inner ear? No. Where is the defect? In the roof of the inner ear, in the base of skull covering the superior semicircular canal. This is what is known as superior semicircular canal dehiscence syndrome. We will do that in detail later on, but for now, when you should know whether superior semicircular canal is bulging and what can be the defect in relation to that. And this superior semicircular canal, superior semicircular canal dehiscence is also known as third window syndrome. Why it is known as third window, that we will see later on. So we saw that the superior semicircular canal bulges in the base of skull because it is known as superior. So that is why it is going superiorly. So now you will tell me, where will the lateral go? What lies lateral to the inner ear? Very good. The middle ear lies lateral to the inner ear, which means that the lateral semicircular canal will, if it is going laterally, it is going towards the middle ear. The middle ear lies lateral, yes or no? What lies medial to the inner ear? Medial to the middle ear. Yes, medial to the middle ear is inner ear. So what lies lateral to the inner ear? Middle ear. So the lateral semicircular canal bulges towards the middle ear. That is why it is known as lateral. It is going the lateral direction. So, and the posterior will bulge posteriorly, that is towards the mastoid. Now, after the 3 semicircular canals, we have the part of the bony labyrinth around the next part of the membranous labyrinth. So tell me about, after the 3 semicircular canals, what are the parts of membranous labyrinth? Yes, very good. The utricle and saccule. So the part of the bony labyrinth around the utricle and saccule is what is known as vestibule. So this part around the utricle and saccule, this is what is known as vestibule. Very easy to remember. with V, you can remember it is around U. It is around utricle and saccule. Now every part of ENT, whether it is the ear or the nose or the throat, has a vestibule. What is the vestibule of the nose? That is the lowermost part of the nose, nostril inside is what is known as vestibule of nose. So a vestibulitis of the nose is just an infection of the lowermost part, that is a furuncle of the nose. Whereas a vestibulitis of the ear becomes such a severe infection, it becomes a labyrinthitis. So what is vestibule of the labyrinth? It is the bony labyrinth around the utricle and saccule. Now tell me the next part of the membranous labyrinth. Yes, the scala media. Yes, so now the scala media divides the bony labyrinth into a part above it and a part below it. The part above it, since it opens into the vestibule, this is what is known as scala vestibuli. This is known as scala vestibuli, and the part below it is what is known as scala tympani. Because the media lies in between these two, it is known as scala media. So at the apex of the cochlea, the scala vestibuli and the scala tympani communicate with each other. This communication is what is known as helicotrema. This is known as helicotrema. So now let us quickly write the parts of the bony labyrinth. Yes, so for that we'll first write the membranous labyrinth. So in the and here we have the bony labyrinth. The bony labyrinth develops through which ossification? Yes, I told you it first develops into cartilage and then this cartilage develops into bone. So that is what is known as enchondral ossification. So it develops from mesoderm around the membranous labyrinth. Membranous labyrinth flows from ectoderm, surface ectoderm, we saw that. Yes, and bony labyrinth will develop from mesoderm, and by which ossification? By enchondral ossification. This is a question of your exam. It develops from enchondral. Enchondral means it first develops into cartilage, which then develops into bone. So what are the parts of the bony labyrinth? Let us do. Yes, so from in the membranous labyrinth, we have the 3 semicircular canals. Around the 3 semicircular canals, in the bony labyrinth, we again have the 3 semicircular canals. Yes, we have the superior, we have the lateral, and we have the posterior, and we have the lateral. So superior semicircular canal, can you tell where does it project? Yes, the base of skull, that is the arcuate eminence. A deficiency there is third window. The lateral semicircular canal will bulge on the middle ear. Posterior will go towards the mastoid. Now after the 3 semicircular canal, in the membranous labyrinth, we have the utricle and then we have the saccule. So this part of the bony labyrinth around the utricle and saccule, what is that known as? Yes, it had the name with V. Around U is V. So that is what is known as the vestibule. That is known as the vestibule. Now after the saccule, the next part is the scala media, and around the scala media, the part of the labyrinth is what is known as, the part of the bony labyrinth is known as bony cochlea. It is known as bony cochlea, or it can be just named as cochlea, which means that if I ask you what are the parts of the bony labyrinth, yes, we have the semicircular canals, we have the vestibule, and we can say it is the cochlea. Now this bony cochlea actually comprises of 2 parts, above and below the scala media. So what are these 2 parts? Above it is known as scala vestibuli, and below it is known as scala tympani. Both these are parts of bony cochlea, or just cochlea when we say, is scala tympani. So now we know the parts of the bony labyrinth also completely. So now what we need to know is the connections between the inner ear and the middle ear, inner ear and the brain. Now when we started with this picture, I just told you that yes, there are connections between the middle ear and the inner ear, and there are also connections between the inner ear and the brain. Now can you think and tell me that these openings, which are the connections between the middle ear and inner ear and brain, they will be present in which part of the labyrinth? Will they be present in the membranous labyrinth or the bony labyrinth? Yes, very good. They will be present in the bony labyrinth. Membranous labyrinth is a complete sac, not connected anywhere to anything. So they will be present in the bony labyrinth. So let us see where these connections are, or what these connections are. So first let us see the connections between the middle ear and the inner ear. Now in between the middle ear and inner ear, we have a very, very important connection that you already must be knowing. Yes, and that is the oval window. That is the oval window. Yes, so what is the normal function of the oval window? Why do we have a connection between the middle ear and inner ear? Yes, because when the sound comes, it comes from the external ear to the middle ear and then it has to go to the inner ear. So it has to go through some connection between the middle ear and inner ear, and that connection is the oval window. On the oval window is present the third ossicle, the footplate of stapes, as we can see here. Yes, so this, when it vibrates, it sends the vibration into the inner ear fluid. Yes, which fluid is this here? Around the membranous labyrinth. Yes, this is the perilymph here. So it sends the vibration into the perilymph. So what extra do we need to know about the oval window? Till here we already know about the oval window, that it is a connection between the middle ear and the inner ear, through which the sound vibrations go into the inner ear. Yes, so now what we need to know is that what exactly is the oval window connecting the middle ear to? Which means that if I pass something from the oval window into the inner ear, where is it going to reach? Yes. Second, if there is any abnormality of this oval window, abnormality of this connection, what is the pathology that is going to happen? So now let us see that if the first thing that we need to understand and remember is that this oval window connects the middle ear to which part of inner ear? Yes, are you seeing it here? It is connecting it to the part around the utricle and saccule. What is that part known as? Yes, that is known as vestibule. So can you see that is so easy to remember? Yes, that is the V for vestibule is telling you that the V of oval window is connecting the middle ear to it. So the answer is in the name of the window itself. The V of oval window tells you that it connects the middle ear to V of vestibule. So will you ever forget that? No. So let us quickly write this down. Yes, so in the just lateral to the bony labyrinth, lateral to it is the middle ear, Now in the semicircular canals, do we have any projection of the semicircular canal in the middle ear? Yes, some semicircular canal. Which one is that? Very good, the lateral semicircular canal. So here the lateral semicircular canal will produce a bulge here in the middle ear. Yes, so that is very important for you to remember. Because if there is any disease of the middle ear, it can lead to which erosion of which semicircular canal most commonly? Yes, the lateral semicircular canal. So what we are doing here in anatomy or the embryology is not just the anatomy or the embryology which you were supposed to know when you were in the first year. Now whatever you will do in clinical subjects, what you are supposed to know is the clinical anatomy, the clinical significance of that particular part of the anatomy, and that is what is asked in your exams. Yes. So here we have the bulge of the lateral semicircular canal. Vestibule, is it connected to the middle ear? Yes, through the window which is known as oval window, and the V of the oval tells you that it connects it to the V of vestibule, and vestibule is around utricle and saccule. Now, why is it significant to know? Why is it important to know this? Yes, so here in the oval window, the normal function is conduction of sound. So what can be the abnormality that can occur because of this connection? Now since this transmits the sound from the middle ear to the inner ear, what if this oval window footplate, or this oval window was fixed? This footplate was fixed. It was not moving. So what will happen now? Now the sound vibrations from the middle ear will not be able to go into the inner ear. Will that lead to hearing loss? Yes, that will lead to hearing loss, and that hearing loss which occurs because of fixation of the footplate of stapes is what is known as otosclerosis. That is what is known as otosclerosis. So yes, what can be the abnormality? It can get fixed. If it gets fixed, then that condition is what is known as otosclerosis. Now, what is the other abnormality that can occur because of this connection? Yes, we know that the oval window connects the middle ear to the vestibule, and vestibule is around the utricle and saccule, which means that this is the oval window. Normally, the footplate on the oval window moves Very little. It moves only that much that it can send the vibrations into the inner ear fluid. It does not move that much that it can touch the utricle and saccule, or it can excessively stimulate the utricle and saccule. What will happen if the utricle and saccule will get excessively stimulated by sound, by movement of the footplate of stapes? What will happen? Yes, along with the movement of footplate of stapes, patient will also have vertigo because of stimulation of utricle and saccule. What do you have in the utricle and saccule? Yes, we have the maculae. So maculae will get stimulated, leading to vertigo. Yes, so we need to know that because of this connection between the middle ear and inner ear, because of the oval window there, because of the footplate on the oval window, the footplate can also stimulate the utricle and saccule, leading to vertigo. But for that, the utricle and saccule have to get overstimulated, excessively stimulated, and that will happen only when the utricle and saccule is in close approximation with the footplate, because usually it will not stimulate it that much. Usually it will not be able to touch it. So when will that happen? Yes, that can happen in two situations. Either the utricle and saccule is dilated and it is very near to the footplate, or second, the footplate is hypermobile. The footplate is moving excessively. So in these two conditions, the footplate can touch the utricle and saccule and stimulate it, leading to vertigo. So the second is that it can lead to vertigo. Through these connections, the footplate can touch the utricle and saccule. Footplate can touch the utricle and saccule, stimulate the utricle and saccule. So this will happen in two situations. Two situations: when the utricle and saccule is dilated. Yes, do you know if in any condition where the utricle and saccule is dilated? Yes, I told you that what happens in Meniere's is, yes, Meniere's. The moment you hear of Meniere's, what should come to your mind is it is a disease of inner ear where the endolymph increases, so the membranous labyrinth gets dilated. So when the membranous labyrinth gets dilated, the utricle and saccule get dilated, they come very near to the footplate. Now the footplate is able to stimulate it, leading to vertigo. Or it can happen when the footplate is hypermobile. Footplate is hypermobile. So this happens in Meniere's dilatation, and the hypermobility of footplate of stapes occurs in syphilis, in congenital syphilis. So now we know everything about the oval window. Yes, so quickly before we proceed, you are going to tell me what is the important connection between the middle ear and the inner ear responsible for conduction of sound, on which is present the footplate of stapes. Yes, the oval window. Oval window connects the middle ear to which part of inner ear? Vestibule. Vestibule is around utricle and saccule. Yes, can the footplate get fixed? What is that known as? Orthostosis. Can it lead to stimulation of the utricle and saccule, overstimulation of the utricle and saccule, leading to vertigo? Yes. In which two conditions? Dilatation, that is known as Meniere's, or in hypermobility of footplate of stapes. So now we know everything about the oval window. Now we have another connection between the middle ear and inner ear. And what is that connection? Yes, that connection is what is known as we can see here, this connection is what is known as round window. This is known as round window. So we have two connections between the middle ear and inner ear, oval window and round window. Now we already have one connection, the oval window, that is for transmission of sound into the inner ear. Why at all do we have another connection? What is the significance for round window? Yes? Any idea? Yes, that is also for transmission of sound. That is also for conduction of sound. So for conduction of sound, why do we need two windows? Yes, just think and tell me that the oval window is present, it connects the middle ear to which part of inner ear? To the vestibule. And vestibule is around utricle and saccule. Whereas, where is the sensory end organ of hearing present? Yes, that is present in the scala media. That is the organ of Corti. Where is that present? Yes, that is present here. The scala media in the organ of Corti. So how can movement of perilymph here in the vestibule stimulate the scala media, the organ of Corti in the scala media? Yes, so now just listen to this and understand this carefully. When the footplate moves, the vibrations go into the vestibule and then they go into the scala vestibula in this direction. Just see here, they go from the vestibule in the scala vestibula in this direction and then through the helicotrema in the scala tympani in the reverse direction, which means, yes, from the footplate it is going through the scala vestibula in this direction and then through the scala tympani in the opposite direction. In the opposite direction. So this opposite movement is creating a shearing action. This shearing action stimulates what is present in between, that is the organ of Corti, and that leads to stimulation of organ of Corti, that leads to its sensing sound. So yes, the first thing that we need to know in the round window is that this window connects the middle ear to which part of inner ear? If we pass something from the round window into the inner ear, where in the inner ear will it reach? Yes, so here we have the round window. The round window is covered by a three-membrane structure, a three-layered membrane which is similar to the tympanic membrane. So this is what is known as secondary tympanic membrane. This also has three layers like the tympanic membrane. We'll see that later on. So this is what is known as secondary tympanic membrane, and from the name of secondary tympanic membrane gets the name scala tympani. Scala tympani. So both the windows have the answer in the name itself. V of oval tells you it is connecting the middle ear to V of vestibule. V of vestibule. And the secondary tympanic membrane of the round window tells you it is connecting the middle ear to scala tympani. Now, is it important to remember? Yes, it is very important to remember. Now, how it is important to remember, we'll just see. So, let us first write it here. Yes, the scala tympani has a connection with the middle ear, and that is the round window, and that is connected by secondary tympanic membrane, hence is the name the scala tympani. Hence is the name scala tympani. So now let us see what the significance of the round window is. The round window has a normal function. Normal function is again sound transmission. So for normal transmission of sound to occur, this shearing action has to occur. And for this shearing action to occur, opposite movement have to occur. For the opposite movement to occur, we need two mobile windows. Yes, so what are the two mobile windows? Oval window and round window. Whereas if there is abnormal communication, abnormal window at the bulge of the superior semicircular canal in the base of skull, what is that known as? That is known as third window, because normally we are supposed to have only two windows. So what is the significance of this other connection? Let us see. Now, have you heard of cochlear implant? Cochlear implant? Yes. Now, in cochlear implant, the name itself tells you that we are putting some implant in the cochlea. What is the cochlea? Inner ear. Now, the first and foremost thing that we need to know in cochlear implant, you must have heard cochlear implant name so many number of times. Yes, the cochlear implant is the first artificial sense organ. So, the first thing that we need to know is that when will you go for a cochlear implant? What is defective that you replace with the help of cochlear implant? Yes, it is the first artificial sense organ. It is the sense organ of hearing. So, what actually is the sense organ of hearing? Yes, organ of Corti. So it is the artificial organ of Corti, artificial sense organ of hearing. So what does it replace? It replaces the organ of Corti. So whenever the organ of Corti is defective, we can replace it with the help of cochlear implant. So now what we do in cochlear implant is, we drill the bone here and we place the main body of implant here. And what we have to pass and replace the organ of Corti is the electrodes. So the electrodes we pass from the mastoid into the middle ear, and then from the middle ear we pass it into the inner ear. Now we are going to see this in great detail later on. For now, just understand that we have got the electrodes up to the middle ear. So you are operating and the electrodes are in the middle ear. Now you want to pass the electrodes from the middle ear into the inner ear. So you are the surgeon. How many options do you have to pass anything from the middle ear into the inner ear? Yes, very good. You have two options. Which two options? Oval window and round window. So you are the surgeon. You will decide you are going to pass it through which window. Through which window? What have you decided? Yes, very good, the round window. Why did you not choose the oval window? Yes, because the oval window is covered with footprint of stapes. So if we have to pass something through the oval window, will we not have to dislodge the footprint of stapes? Yes, and if we dislodge the footprint of stapes, yes, it is better. Will it not affect hearing? Yes, and also if you are passing something through the oval window, where in the inner ear are you passing it? Into the vestibule. And what's the vestibule around? Utricle and saccule. So if you're passing something through the oval window into the inner ear, can it not stimulate the utricle and saccule leading to vertigo? Yes. So if there is anything that we want to pass from the middle ear into the inner ear, we always choose which window? Yes, we choose the round window always. So yes, this is a very, very important question, very commonly asked in your exam, that the electrodes of cochlear implant are introduced into the inner ear through which window? Through round window. Yes. So next year the question changed. And what was the question? In a patient of mean ears, gentamicin is passed into the inner ear through which window? Again, yes, round window. Anything that we are passing from the middle ear into the inner ear, that is round window. So don't just ratify, okay, cochlear implant, round window. No, anything from the middle ear into the inner ear. Steroids, when they are passed from the middle ear into the inner ear in a patient of sudden sensorineural hearing loss, that was again a question of your exam. It is passed through which window? Yes, again through round window. So any drug, anything that you want to pass from the middle ear into the inner ear, you are choosing which window? Yes, we are choosing the round window. So now again next year the question changed. And what is the question next year? The electrodes of cochlear implant are placed in which part of inner ear? Now they are not asking they are passed through which window. It is asked they are placed in which part of inner ear. Yes, so now this you will tell me, because I have told you that if you are passing something through the round window is connecting the middle to which part of inner ear? Yes, the secondary tympanic membrane gives you the hint, scala tympani. So where are the electrodes of cochlear implant placed? Yes, they are placed in the scala tympani. A very, very common question. Yes, so they are passed through the round window. They are placed here in the scala tympani. And from here, they replace the organ of Corti that is present in the scala media. Now that is replaced. Instead of that, now we have the cochlear implant, and this cochlear implant sends the impulses now to the cochlear nerve, the eighth cranial nerve, which was starting from the organ of Corti. Now that is getting stimulated directly through the electrode. So now the next year again they change the question. What was the question? The electrodes of cochlear implant replace what? Yes, first they asked it is introduced into the inner ear through what? Next they asked that it is placed where in the inner ear. Now they replace what? They replace what? Yes, they replace the organ of Corti. And again next year the question changed, and that was that they stimulate what? So what do they stimulate? Yes, they stimulate the cochlear nerve, which means if there is any defect of the organ of Corti, along with that the cochlear nerve is absent. The cochlear nerve is gone. In this patient, in this child, will you like to go for a cochlear implant? No. So you have to test whether the nerve is functioning normally or not before you go for a cochlear implant. So you can see that all this is so simple when you understand this. So now let us write what is the clinical significance. What is the clinical significance of round window? Yes, the first is that anything that we want to introduce from the middle ear into the inner ear. What are these structures? Yes, this can be cochlear implant electrodes, or they can be drugs. Which drugs that we know of? Yes, they can be steroids. They can be gentamicin. Why gentamicin is passed, all that we'll see later on. Yes. So now we know that if we are passing anything from middle ear into the inner ear, we have to choose the round window. And what all do we know about the cochlear implant till now? Yes, the cochlear implant. Yes, first it is passed through. It is passed through round window. It is placed in scala tympani. It replaces organ of Corti, and it stimulates the cochlear nerve. Okay, so now do you know everything about the connections between the middle ear and inner ear? Is that very clear? Quickly I will repeat for you. So how many connections do we have between the middle ear and inner ear? Yes, you are going to answer this. How many connections? Yes, the oval window, and second is round window. Yes, if I pass something through the oval window into the inner ear, where will it reach? Vestibule. Vestibule is around utricle and saccule. If I am passing something through the round window, where will it reach? Yes, scala tympani. Very good. So now answer these questions. The vibrations of the footplate of stapes, are directly transmitted to scala vestibuli, scala tympani. Scala vestibuli or scala tympani or scala media. Yes. Yes, they are directly transmitted to. Now here vestibule is not given in the choice. If vestibule was given in the choice, that would be the answer. But here vestibule is not given in the choice. This was a question asked in your exam. Yes, so if vestibule is not given in the choice, we know from the vestibule where does the vibration go? Into the scala vestibuli. So what will be the answer? Scala vestibuli. Many a times you see the simplified diagram. What's the simplified diagram? It is clearly showing that the footplate of stapes, yes, the vestibule they have missed here, it is transmitting vibration to scala vestibuli, and the reverse direction, the sound vibrations are coming through the scala tympani, so making the round window move outside when the oval window is moving in, creating the shearing action. So this is an oversimplified diagram, but anyway this helps you to clear that yes, it is going directly through to the scala vestibuli. The electrodes of cochlear implant are introduced into the inner ear through? Yes, through the round window. So we know about these two windows. Now the fluid that is present inside the membranous labyrinth, what is that called as? Endolymph. Yes. What is the fluid outside the membranous labyrinth known as? Yes, perilymph. The endolymph is produced in the membranous labyrinth, absorbed from the membranous labyrinth. Tell me, production occurs from? Very good, scala media. Absorption occurs from? Endolymphatic sac. Now the perilymph is a derivative of CSF. How does it come from the CSF into the inner ear? Through a connection between the CSF and the inner ear. This connection, yes, you are not able to see in this picture, this connection is what is known as cochlear aqueduct. Okay, so from the inner ear to the brain, we have this connection which is known as cochlear aqueduct. It is known as cochlear aqueduct. Okay, so what is the normal function of cochlear aqueduct? Yes, it is responsible for putting the CSF into the inner ear to form perilymph. So CSF from here goes through the cochlear duct to form perilymph. So this is the normal function. What can be the pathology that can occur because of this connection? So now let me ask you this question. And yes, this was a question of your exams. A 5-year-old child of meningitis develops labyrinthitis. I hope you're getting it. Yes, meningitis from the brain. It is developing labyrinthitis. This could happen through, yes, through oval window, through cochlear aqueduct, through round window, through Hurter's fissure. Yes, what should be the answer? Yes, through cochlear aqueduct. Yes, now suppose cochlear aqueduct was not there in the choice, what would have been given in the choice? Which would be the answer? Which means, is there any connection between the inner ear and brain through which any infection from the brain can come into the inner ear? Meningitis can become labyrinthitis, or any infection of the inner ear can go to the brain, any labyrinthitis can become meningitis. Yes, very good. Internal acoustic meatus. So these are the two connections between the inner ear and the brain. The internal acoustic meatus. And what is the normal function of internal acoustic meatus? Which nerves enter into the inner ear through the internal acoustic meatus? Yes, the 7th and the 8th cranial nerve. And if there is any abnormality that can occur through these connections, what is that abnormality? Yes, any infection can go either ways. Any labyrinthitis can become meningitis, meningitis can become labyrinthitis. So any labyrinthitis can become meningitis. Meningitis, and this can happen through two connections. Which two connections? Yes, one is the internal acoustic meatus and second is cochlear aqueduct. Now, was a question asked in your exams? A 6-month-old child of meningitis has been treated for the same. So here's a 6-month-old child who has meningitis and he has been treated for meningitis. You have beautifully treated him for meningitis. Now, before discharging this patient, before discharging this child, which is the investigation which is mandatory? Yes, which is the investigation you will get done before you discharge this child? Yes, we will get done a hearing test. Yes, that hearing test is BEHRA. What exactly is BEHRA? All that we'll see later on. For now, you need to know that yes, we will get a hearing test. So, why at all do we need to get a hearing test done in a child who has developed meningitis? Can meningitis lead to hearing loss? Yes, meningitis can lead to labyrinthitis through these two connections. And can labyrinthitis lead to hearing loss? Yes, if there is labyrinthitis leading to hearing loss, which means what has got destroyed? Yes, what is the part of hearing in the inner ear, in the labyrinth? Organ of Corti. Yes, so you got a hearing test done. And what you saw was that the hearing is gone. Can you help this child? Can you do something for the child? Now, if you cannot do anything for the child, then what was the significance of getting the test done? Yes. So, can you help this child? Yes, the organ of Corti got destroyed. So, do we have something with which we can replace the organ of Corti? Yes, very good, cochlear implant. And if we have to place the implant, we will pass into the inner ear through which window? Very good, round window. Where will we place it in the inner ear? Scala tympani. And it will replace organ of Corti, stimulate what? The cochlear nerve. So, we will also test whether the nerve is functional or not. If the nerve is functional, we will go for cochlear implant. Now, do we do this test in an adult also who has developed meningitis? What? Yes or no? Do we have these connections, the cochlear aqueduct and the internal acoustic meatus only in children? Or do we also have it? Yes, we also have it. So, in adults also meningitis can lead to labyrinthitis. So, do we get this hearing test done in an adult who has developed meningitis before discharging him? Yes, no? Should get it done, but what is more important, to get it done in a child or in an adult? Very good, in a child. Why not in an adult? Adult will tell you I am not hearing. Will a child of 6 months tell you that I am not hearing? No. So, suppose you forgot in a child that something like this can happen from meningitis, there can be hearing loss, and you send the child, you discharge the child. Now, when the child grows, when the child is now 4 years, 5 years, 6 years, now the parents will know that the child is not hearing. So, the parents will now bring the child to you. So, will it make a difference that you made the diagnosis there itself when the child was 6 months, or you are making the diagnosis now when the child is 5 or 6 years of age? Can you put a cochlear implant in both the instances? Yes, we can put. But the result will be better in 6 months, or will it be better in 5 years? Yes, the result will be better as early as we put. Why that? Because the speech center is maximally active at 3 years of age. So, it is at that time that the neural interconnections are developing. So, if we give hearing before that, the neural interconnections will develop properly, the speech that will develop will be proper. So, the earlier we put, the better will be the result. So, that is why cochlear implant is put early. It is put as early as 1 year of age. Yes, 1 year of age. Why? Because the tissues before that are too small to put the implant. So, it is put at 1 year of age. This does not mean that before that you will not do something. You will give some hearing amplification before that. But yes, that is put at 1 year, and that was again a question of your exam. So, this we will add on here, that it is put at 1 year. It is done earliest at 1 year of age. So, now we know the important connections between the inner ear and the brain. So, in fact, we know the important things, everything that we are supposed to know in the inner ear. So, now let us have a look at this picture. Yes, this is a beautiful picture that we are seeing, where we are seeing here is the middle ear, and the middle ear is, yes, connected to the inner ear by, can you tell me how many windows? Yes, this is the oval window and this is the round window. Yes, through the oval window it is connected to which part of inner ear? Vestibule. Vestibule is around. Yes, the utricle and saccule. So, here we have the vestibule, and here through the round window, where is it? Yes, that is the scala tympani. And can you see here, this here is the turns of the cochlea. How many turns? 2, 3 by 4 turns. So, this here is the basal turn, and this here is the apical turn. The apical turn is for what frequency? For low frequency. Basal turn is for what frequency? For high frequency. So, now, yes, keep your pens down, sit straight. Yes, very good. So now you are quickly going to tell me that, yes, what is the sensory end organ of balance in the 3 semicircular canals? Yes, very good. Cristae. For macula is present in maculae in the utricle and saccule. Macula is responsible for linear aspiration. It is present in utricle and saccule. Utricle and saccule is present in vestibule. Vestibule is connected to the middle ear by, very good, oval window. Oval window is covered with footplate of stapes. Yes, and the second connection between the middle ear and inner ear is down window. And down window is covered with a membrane. Secondary tympanic membrane connects the middle ear to which part of inner ear? Scala tympani. Yes, that gets the name from secondary tympanic membrane. Can any meningitis lead to labyrinthitis? Can any labyrinthitis also lead to meningitis? Yes. Through how many connections? 2 connections. Which 2 connections? Internal acoustic meatus and cochlear aqueduct. Yes. What is the sensory end organ of balance for rotation acceleration? Cristae. Where is that cristae present? Semicircular canal. For hearing, what do we have? Organ of Corti. Organ of Corti can be replaced with cochlear implant, which is done earliest at 1 year of age. It stimulates what? Cochlear nerve. Yes, so now we know the structure of the membranous labyrinth. When I say the structure of membranous labyrinth, does the picture come to your mind? It should come to your mind. Yes. So we know the function of membranous labyrinth. Yes, hearing and balance. So any defect here will lead to hearing loss and imbalance. What I go? Yes. Do we know the structure of bony labyrinth? Yes. Semicircular canals, the vestibule, cochlea. Yes, we know it in detail. We know the 2 fluids, from where they are coming, where they are getting absorbed. Do we know the connections between of the inner ear, laterally with the middle ear and medially with the cranium? Yes. Do we know the normal function and also the abnormalities? Yes. So that is what we are supposed to know in the inner ear. So now, the picture that I showed you was an oversimplification of the actual picture of the inner ear. Now let us see how actually the semicircular canals look like. The semicircular canals, I told you, they are named according to which direction they are going. Yes. So let us see this. Yes. So this is exactly how the semicircular canals look like. So this is the bony cochlea, bony labyrinth that we are seeing. This is the bony cochlea here. Yes. We have, this is the vestibule part. We have the semicircular canals. Now where is the semicircular canals? We have, this is the superior semicircular canal, this is the posterior semicircular canal, and this is coming laterally, this is the lateral semicircular canal. So now what you need to know is that when this picture is given in your exam, how do you identify any of the structure is marked, and you are supposed to answer what is that part that is marked. Now if it is the cochlea that is marked, that is very easy. If it is the vestibule that is marked, again that is very easy. But in semicircular canals, you get confused which one is which semicircular canal. So don't get confused, it is very simple. We know that in between 2 semicircular canals, we have a common opening, a common crust commune. What are these 2 semicircular canals? Yes, so superior and posterior. So let us see, where do we have a common opening? Yes, we have a common opening here in between these 2 canals. So one of them is superior, one of them is posterior. Yes. So here we have, let me just draw. Yes. So this here, yes, if I draw like this, so this, just imagine this to be like a box of the middle ear through which you are seeing the inner ear. Yes. So which means that all these structures, we know that through the middle ear we can go into the inner ear, and that is through 2 openings. This is the oval window and this is the round window that we already know till here. Yes. So now what we are seeing is that we have some bulge of semicircular canal. We have some bulge of some semicircular canal in the middle ear. What is that semicircular canal? Yes, that is the lateral semicircular canal. So the semicircular canal which is going totally in a different direction from the superior and posterior, that is the lateral semicircular canal. The semicircular canals which have a common opening between them, one of them is superior, one of them is posterior. So which one will be the posterior, which one will be the superior or the anterior? Now the posterior semicircular canal, where does that go? Yes, the posterior semicircular canal goes posteriorly towards the mastoid. So, yes, behind the middle ear is the mastoid. Behind the middle ear is the mastoid. So this posterior semicircular canal is going posteriorly towards the mastoid. Now, if the mastoid is not drawn, how do you know that which is the semicircular canal which is posterior? Yes, the lateral semicircular canal is coming towards the middle, posterior is going towards the mastoid. So both of them, the middle and the mastoid, are close together. So the lateral and the posterior semicircular canal are close together. That is how you have to remember, which means let me just remove everything. Yes, let me just remove everything and let me ask you which is what semicircular canal. Yes, so we know that the semicircular canal which is projecting towards the oval window and the round window, that will be which semicircular canal? The lateral semicircular canal. The semicircular canal which is close to the lateral semicircular canal, because that will also be going towards the mastoid and middle are together. So the one that is close to the lateral semicircular canal, that is the posterior semicircular canal, and the one that is totally separate but has a common connection between with the posterior semicircular canal, that is the superior semicircular canal. Is that clear? Now, when the patient is in the lying position, the same picture is given like this. The same picture is given like this to you. So again, we have, you will be able to identify which semicircular canals, even if this picture is given. Yes, so the first thing that we are going to see is the common opening. Common crus is in between which two semicircular canals? Superior and posterior. So we have the common crus here, a common opening. So one of them will be superior, one of them will be posterior. Which is the semicircular canal which is pointing toward these windows? Yes, these windows are laterally in the middle here, so that will be the lateral semicircular canal, and the one that is in close to the lateral semicircular canal, that is the posterior semicircular canal. Is that clear? Yes. Now in this picture, you are going to tell me. Yes, you are going to tell me which of the semicircular canals is which one. Yes, very good. So first what we are going to think, the first step is see the common crus. So where is the common crus? Yes, we can see this is the common crus. So one of them will be anterior, one of them will be the posterior semicircular canal. Yes, and this, the totally different will be the lateral semicircular canal. Different from these two will be lateral. Okay, so which one is close to the lateral? Yes, the posterior semicircular canal. So this is posterior semicircular canal and this will be the superior, or this is known as anterior semicircular canal, or the superior semicircular canal. Now another important thing that you need to know is that does the endolymphatic sac drains the endolymph into the CSF? That you already know. Does it drain? No, it does not drain. What does it do? It absorbs the endolymph. Yes, so where exactly is the endolymphatic sac present? It is not opening into the CSF. Yes, definitely not into the CSF. So where is it present? Yes, just see here. This is the CSF here. This is the meninges. It is present outside. Yes, so for this, let us understand this. Okay, so we have the two hemispheres here of the brain. Yes. Now this we know, the brain is lined by the meninges. Which are the meninges? Yes, we have the pia. We have the pia just abutting on the brain, that is the pia. We have the arachnoid, and then we have the dura. Now dura at the level of the brain, and this is the skull here. This is the skull. Now the dura at the level of the brain has two parts. One is the meningeal layer which is attached to the meninges, and the second is the part which is adherent to the skull bone. This is known as the endosteal layer. So where is the endolymphatic sac present? The endolymphatic sac is present here. The endolymphatic sac is present intradurally. It is present in between the endosteal and the meningeal layer of dura. So it is the endolymphatic sac is present intradural. Which means that if we have to reach the endolymphatic sac, we just need to drill the skull bone. We will not need to enter into the meninges. Yes, we just need to drill the skull bone. Along with that, the endosteal layer of dura. We do not have to enter into the meningeal layer of dura. You do not have to enter into the meninges. It is lying outside that. Okay, so now during development of the inner ear, there can be certain congenital anomalies. Now, what can be the anomalies? Let us see that. But before that, I want you to know that is the inner ear, we know, develops in two parts. The upper part is the three semicircular canal and the utricle. This develops together. This is what is known as pars superior. Pars superior. this develops early, and this is the upper part, this develops early. The lower part, that is the saccule and the cochlea, and the membranous cochlea, the organ of Corti, the scala media. This is what is known as pars inferior. This is known as pars inferior, and this develops later on. Since it develops later on, it is more exposed to the toxins, and this is the part that usually gets malformed. So what we will see is that most of the anomalies, the congenital anomalies, most of the congenital aplasias of the inner ear are confined to the scala media and the saccule, or the whole of the inner ear is not developed, but nothing specifically confining only to the pars superior part. Yes, so let us see what are the congenital aplasias. So first is known as Michael. Now Michael, how do we remember Michael? Michael Jackson is no more, so this is totally absence of the inner ear. Absence, total membranous labyrinth is not developed at all, and membranous labyrinth is absent. Then is Mondini. What is Mondini? Mondini is that the scala media or the cochlea has only 1.5 turns. There are only 1.5 turns in the cochlea. Yes, so which turns do we have? We have the basal turns, and we have some turns missing, only 1.5 turns. Now the next is Alexander. Now what is Alexander? Alexander is deformity of the basal turn. So here the basal turn is deformed. If I ask you which frequency sound will be affected here, yes, it will be only the high frequency sound. And Shibi. Shibi is the most common, and it involves deformity of S and C, as in the name. What is S and C? Yes, C is the cochlea, that is the scala media, and the S is the saccule. S is the saccule. These two lie together and they are the pars inferior. Yes, the S, don't confuse S with the semicircular canal. The cochlea, C is cochlea. Along with the cochlea, what is present alongside with the cochlea, that is the saccule. So this is deformity of the cochlea and the saccule, and this is the most common deformity, that is C. Now here what is important for you to know along with this is that if there is any Michael aplasia, can you go for a cochlear implant? Michael aplasia? The inner ear is not present at all. Where will you put the cochlear implant? No, so we cannot go for cochlear implant in Michael aplasia. Otherwise, in rest of the aplasias, if the hearing loss is significant, we can go for cochlear implant. So this is what you need to know in the development and some part of the anatomy of the inner ear. So I hope you have a picture of the inner ear. You know the clinical significance of the inner ear. You know the connections of the inner ear. You know the clinical significance of that. So just revise it. Do all the questions from the book as well as from the marrow, and make it sure that it is totally crystal clear for you.